Next topic for your geriatrics are going to be your respiratory and your cardiovascular conditions. Now overall, for the most part, the majority of the treatment is going to be the same as your younger adults, but there are a few specific things we're going to go through and point out. So respiratory up first. First thing is pneumonia. Now we know what pneumonia is, but pneumonia really has a bigger impact on like the very young and the very old, the older adults. The most at risk are going to be your geriatric patients, those who have underlying health problems, which tends to happen more with age. Those who have a weakened or a depressed immune system, which tends to happen a little bit more with age as well. And those who are generally a little bit immobile, or bed confined, or something like that, or things that limit like the deep breathing, your COPD, things like that. So with pneumonia, one of the big things that you want to think about is that your geriatric patients often don't have that classic chills, fever, productive cough, especially if they take some kind of non-steroidal anti-inflammatory medication for like joint pain or something like that. Usually what you'll see instead is they'll have like an acute delirium, acute confusion. They may have a normal temperature or maybe a low-grade fever, a minimal to absent cough. They may even have some kind of abdominal pain, but of course you'll still have your rhonchi and the affected lobes. So your treatment for this is really going to be supportive care, fluids as needed, oxygen as needed. Now you want to consider potentially a CPAP as well. They may benefit from that. And ultimately they need a pneumonia vaccine given, and I think the boosters are done every like 3 to 5 years. It won't work against all of them, but it will help, of course. Of course, that's something that we're not doing on the ambulance, so, but it's one of the things. And then, of course, stop smoking and doing the exercises, respiratory exercises when they are confined to bed. This is like using the spirometer, using the deep breathing, that kind of stuff. COPD. So with the kind of cantankerous thing about COPD is that it can be difficult to distinguish between some of these diseases sometimes. You've got this age-related elasticity problem, and when you've got decreased lung compliance and you've got decreased elasticity and decreased tidal volume, which also occurs with your COPD, it can be kind of difficult to determine, is this some sort of new acute onset of infection, or is this just an acute exacerbation of COPD? What's going on with it? So preventative measures, of course, is stopping smoking, avoiding certain environmental pollutants, which is always a good idea, and then having your flu and pneumonia vaccines regularly. As far as our treatment goes here, supplemental oxygen, of course, consider a CPAP. It's been shown to decrease the morbidity and mortality with your COPD patients. Consider the possibility of a bronchodilator if they've got shortness of breath. Maybe consider some oral or inhaled steroids for inflammation, and they need antibiotics, which we can't give if there's an issue there. Yeah. So asthma. This one, happens anytime, but it could, they can start having it in the older age even if they have not had it their entire life. And the problem with this is if they have like exercise-induced asthma or exertion-induced asthma, then they're more likely to have more attacks than if it's just a environmental thing that they can hopefully avoid the problem. Some of the more common signs you may see with this one, of course, shortness of breath. This chronic kind of dry nocturnal cough is a fairly common symptom as well. And then of course you may hear the wheezing. Now keep in mind, just like with everybody else, just because you don't hear wheezing doesn't mean there's not a problem, because sometimes it gets so tight in there that you can't hear, there's not enough air movement to hear the wheezing in and of itself. So the management's the same as your other age groups. But the biggest thing is if they have cardiac disease, you want to be very careful with your beta-adrenergics because they can exacerbate your cardiac symptoms. So you may have to adjust your dosing or consider some alternatives. Pulmonary embolism. So we know what pulmonary embolism is. This is when you got a blood vessel, gets blocked by clots, supplying the lung tissue. It can cause damage or infarction of the tissue. Usually, these are coming from a damaged heart or a vein in the lower extremity. The risk factors, pretty much the biggest risk factor is going to be your surgical patients. And usually these patients will have some kind of prophylaxis, warfarin, heparin, compression socks, that kind of stuff. Everybody else may just be, an aspirin a day or something like that. So the classic triad of your symptoms, your dyspnea, your chest pain, your hemoptysis, those are often not there. They may not have those warning signs. So they're often, these PEs may be kind of silent, or their only symptom may be tachycardia. Excuse me, not tachycardia, but tachypnea with your geriatric patients. So if you suspect a PE, check the lower legs. Look for any swelling, arrhythmia, the warmness or tenderness that may indicate some DVTs. Right? Be gentle with the leg. Monitor for any changes. Our big treatments, supportive care. Make sure airways open, ventilation is appropriate, and transporting to an appropriate location for care. Moving on to the cardiovascular. So, guess what? Heart disease. Heart disease is the leading cause of death among geriatrics in the U.S. And coronary artery disease specifically is the #1 cause. All right? With these heart attacks and MIs and things like that, the morbidity and mortality goes up dramatically after age 70. With your ACS, your patients may be typical, or more likely they're not going to be they'll present atypical. So they may have that intense chest pain, or they may not have chest pain at all. They may report just some dyspnea. They may have a syncopal episode or weakness. I remember I've had a couple of patients that were geriatrics that, especially women, especially diabetics, all the non-typical presenters, their only symptom was generalized weakness and just like an upset feeling stomach. And then you put them on the monitor and bam, there it is. All right, but so weakness, confusion, nausea, vomiting, fatigue, even just fatigue because their cardiac output's crap because they're having an MI, right? You want to have a real high index of suspicion for ACS in any older patients who have any complaints like that, okay? Always evaluate and try to obtain a 12 lead in your geriatric patients if they have that dyspnea, the syncope, weakness, fatigue, confusion, etc., because it could be a heart attack. So risk factors, of course, gender, ethnicity, family history, genetics, alcohol abuse, having multiple medical conditions, diabetes, things like that. All these patients that are high risk for your heart failure, your ACS, all these things, right? Of course, prevention is weight, changes, lifestyle changes, right? Losing weight, exercise, controlling your blood sugar, healthy diet, not smoking, not drinking, all the fun things in life are gone. With our acute exacerbation, the problem that we're usually going to run into is that pulmonary edema, which means that the heart failure is presenting with usually dyspnea or orthopnea. The orthopnea usually is the nighttime when they call and they go to lay down and then, oops, now I can't breathe. They may have some mental status changes because of the decreased oxygenation. They may have the kind of air hunger sensation. If we have peripheral edema, that's usually going to indicate a worsening heart failure. All right. In absence of any other symptoms, it could be indicative of some kind of other circulatory, integumentary, or infectious condition, cellulitis or something like that. But when you see peripheral edema, you need to think about heart failure. Okay. Now keep in mind, if they are confined to a bed, all right, if they are non-ambulatory, they may present with sacral edema instead, and that's around that sacral region of the spinal column because it's going to be dependent on the lower areas, right? The other thing with the heart failure is that this presentation of the heart failure in a geriatric patient can be kind of marked by or masked by the symptoms kind of that we just associate that are symbolic of old age or are shared with other chronic diseases like dyspnea on exertion, easily getting fatigued, confusion, crackles, orthopnea, dry cough, a lot of times this acute exacerbation, it's related to poor diet, high salt content, which leads to increased blood pressure and increased afterload, which then increases left-side heart failure. Maybe being non-compliant with a medication, having a new onset of a dysrhythmia like atrial flutter or atrial fib, something like that. So there's a lot of different stuff that kind of plays into it, makes them a little more prone to having your heart failure. So we want to make sure, as far as our treatment in and of itself, it's not really all that different from any other population, but we do want to make sure we look at the meds. we want to make sure that we're getting an early reading on their end tidal CO2, make sure that we're having a proper oxygenation. We want to closely monitor any kind of fluids. We don't want to put them in any more fluid overload and make it worse. We want to consider using a CPAP. We want to consider maybe using some cardizem if they are in a AFib or A-flutter or something like that. All right. So our dysrhythmias are going to happen when the heart is going too fast or too slow. We know this, right? There's some kind of interruption, some kind of malfunction. Something's not right. Got a funky little beat or beats in there, okay? Now, of course, we're familiar with our AFib or A-flutter. The AFib is probably the most common dysrhythmia among your geriatric patients, and of course, we know it increases the risk of stroke and heart failure. But, you know, the blood's not moving appropriately, so that kind of encourages your clot formation and increases the chances that this clot may travel, cause the brain, go to the brain, cause a stroke, something like that. Another common dysrhythmia for your geriatrics are going to be bradycardias. Now, there's several different reasons why bradycardias are more common. Perhaps the most common is just because you've got an aging conduction system. You know, the older things get, the more they tend to wear out. And so when you've got this aging conduction system, it may present like a sick sinus syndrome or AV block or something like that. Perhaps the patients are taking beta blockers or calcium channel blockers. Those are going to cause slowing of the heart and can cause excessive slowing of the heart, especially if they are maybe have missed taken a dose, take an extra dose or something like that. The patients, even just something as simple as the constipation can cause bradycardia because they're bearing, they're constipated, and so they have to bear down more when they have a bowel movement, which activates the vagus nerve. If the bradycardia is persistent, then oftentimes it will be treated with an internal pacemaker. Treatment here, same as usual. Now, hypertension. So hypertensive crisis, with your geriatrics, more than 1/2 of all geriatric patients are hypertensive. Most of them have just an isolated systolic hypertension, and it's due to a loss of arterial elasticity, so the vessels just don't respond as well as they used to. Controlling the systolic and the diastolic hypertension helps prevent your strokes and your heart attacks, but with your hypertensive emergencies, they really need a controlled decline in blood pressure we can't do it in the field. The problem is like, say if you use like a nitro or something like that for a hypertensive emergency, then you have a higher risk of rebound hypertension once that wears off, okay? If you do have a patient who has a significant hypertensive crisis, signs of end organ failure, that kind of stuff, where they can't wait to get to the hospital, then you want to use some other, consider some kind of antihypertensive therapy, maybe labetalol or esmolol or something like that, something to gradually lower that blood pressure. Now, regardless of whether you are treating the blood pressure or not treating the blood pressure, one of the best things you can do is if you have somebody who is having a hypertensive emergency, put their head at a 30-degree angle when you put them on the stretcher, and this is going to help minimize intracranial pressure. And we know what our aneurysms are. It's a weakness in the wall, right? We know what the contributing factors are. Nothing new is here. Could be a congenital thing, could be an acquired with age thing. We want to watch out for any kind of headaches or changes in headache patterns that could indicate any kind of cerebral bleed. They may or may not be on anticoagulants, but if they're on anticoagulants, then that could kind of increase the risk for having negative effects from an aneurysm. It increases the time that it takes to stop the bleeding, which can decrease their survivability. Now, the thing with aneurysms is that often they're asymptomatic until they get really big or rupture, right? Some of the earlier signs, especially in a thoracic aneurysm, could be like a difficulty swallowing or hoarseness, and the hoarseness is just from pressure on the laryngeal nerve, but that's really difficult in an isolated setting to differentiate, right? And we don't have imaging to look at things or things like that. If they have back pain, you can examine the chest and abdomen, but you may or may not feel this unless they're fairly thin. Treatment is surgery. We can't do that. So we want to recognize the potential problem, assess them, stabilize them as possible, and transport rapidly to an appropriate facility.